everyone. Welcome. Podcast number 5. Dr. Troy Bell, Dr. Jean Teresa, Dr. Hannah Sahani, we appreciate you viewing it. Certainly, give us your comments, we appreciate you viewing, and we're going to go through today. I think the topic is healthy vision because it's Healthy Vision Month, so we're going to it's a very general topic, so there's a lot of different ways to take this, but at the end of this, hopefully we can convince you guys of why it's important to come in for your annual eye exam, why it's important to get the eyes checked, because there's so many things that you may think things are healthy, but if you're not checked, you don't know, and some of the things you may have, if you find out too late, it may be permanent vision loss and things like that. So of all the things we're going to talk about, I think that's probably very important. Make sure you come in for that annual exam, or if you see any big changes, or if there's something going on that just doesn't seem right with the eyes and vision, give us a call, come in. We certainly want to look at it.
I agree with that. Quality of life is where vision comes in, and quality in some circles really surpasses longevity, and I agree with that myself. So keeping your vision as you get older and your mobility decreases, you're going to be more appreciative of being able to see well, and you can do the maintenance steps to do that and hopefully be in that position.
Yeah, I have not met a person or a career or a job that would ever say their vision was not vital to what they were doing in life, either for themselves or for their family. So I think it's a privilege to take care of healthy vision, poor vision. I think it's a really important job, and I feel very passionately about that.
Well, I think what I'll do is just kind of start with one. We'll go through, and maybe we'll get through a lot of these, or just kind of things to look for with healthy vision, things we're checking. And a big one that everybody talks about, and you always, pretty much everybody knows someone in their family, as far as cataracts. And cataracts, I think sometimes that gets confused with, glaucoma and maybe other things. But cataracts in general, there's different types of cataracts. But if we talk about age-related cataracts, it's a clouding of the lens in the eye that certainly can affect vision if it gets bad enough. And I usually tell most of the patients I see in Florida, we're probably all going to get some sort of cataracts. But, they may not be bad enough in your lifetime for surgery, but for others, they will. There are traumatic cataracts, there's congenital cataracts, there's diabetic cataracts that tend to grow a little bit faster in diabetic patients. But to me, that's a big one, and that's the reason we want to look at the lens, just to kind of make sure the cataracts are not getting to a level where they're affecting your vision, glare, and sometimes even color perception. What do you think? You want to add any more on cataracts or switch to another category?
No, I'm not through on cataracts. Don't rush me. I think they're a very subtle thing. The only evidence-based proof that something causes cataracts is ultraviolet light. And even in its all components, the A component, the B component, the C component, that's getting into the weeds. The important thing you should do is wear sunglasses. And ironically, in Florida, our kids should be the ones wearing the sunglasses, not the old buzzards like me. Right. So it would behoove you to spend the money on sunglasses for the smaller ones in the family. And the long-term benefits of that are significant.
I would agree with that, and the reason for that is because pediatrics and kiddos have such bigger pupils, so they really accept and take in so much more ultraviolet light. And it's very similar to dermatology, where a lot of skin cancers are from childhood sunburns and a lot of the skin exposure as kids. Same thing in the eye. So much sun exposure happens when we're younger. There's only so much we can do about it later. So yeah, protecting the eyes from the sun, early years and on. And there are some cute sunglasses for kids out there.
I know for me, I've always worn, I've got light eyes, so I've always been light sensitive. So I wear sunglasses even on overcast days. I'm just kind of used to doing that.
Mm-hmm. One more thing on cataracts, I do like to tell patients that it's really okay to get cataracts. We are living much longer lives. Our life expectancies have gotten so long. It's the same lens in your eye that you were born with. So there are going to be changes there, and it's something that is okay to show up over time. And that's something that in a normal eye exam, we can diagnose as a normal age-related cataract, or there can be secondary types of cataracts that need to be looked at with a little bit more care and specialty. So that's another reason to get your annual eye exam, to look through that and see if there's some other reason to be worried about cataracts versus just the normal age-related kind.
Well, I think the other topic is the one I see probably most often day to day. is diabetic retinopathy. Certainly with the increase in patients who are more diabetic, more blood pressure issues, day in and day out, I think I probably see that more than anything else with the eyes, as far as, looking at especially for the patients who have those big blood sugar shifts, and it's not under control. Eventually, usually it leads to, hemorrhages, maybe leakage of blood or fluid in the back of the eye, which can cause temporary or permanent vision loss, certainly if it's not addressed and taken care of.
Diabetes is the second major cause of blindness in the United States. And that alone should be a reason to get checked, particularly if you have any of those systemic conditions. And also the medications you take for some of these conditions can cause cataracts or other issues in the eye that also have to be checked, because they're all interwoven. And you have to figure that out, and maybe taking something that benefits you one way and then hurts you in another. And that can be adjusted once the physician has been alerted to that fact.
I think it would surprise a lot of patients, and it usually does, how much we can see in the retina. And I like to tell patients this, it's one of the only places in the human body we can observe your blood vessels without doing anything invasive. And so that's what we're doing, is we're observing your cardiovascular system, and we're checking it to make sure everything looks good. And unless it's in the direct center of your vision, most patients don't know something's showing up in their retina. So that's why we do want to take a look every year.
Well, I know when I first graduated school, and you can attest to this, we didn't have all the nice equipment, the OCTs and stuff we do now. So we relied on that at that time more you just looking in the back of the eye, which we still do. But some of the scans we have, OCTs, visual fields, things like that, can pick up even the slightest changes as far as diabetic retinopathy and things like that. And it's a nice tool to have so we can kind of watch if it's progressing or getting any worse over time.
Oh, the main rule in medicine is the earlier you find something, the earlier you can fix it, as it perhaps is true of any problem. It's almost a universal truth.
Well, I think that this next topic is, especially nowadays, seems to be a very popular topic. I get asked about this probably on a daily basis, especially with the commercials out there for Tepezza and things like that. But thyroid eye disease, as far as someone's on Synthroid, the question is, can my thyroid or my Synthroid or what I'm having, can it affect the eyes in certain ways? And certainly the patients want to know what to look for, what the expectation is, and what can happen.
I will say for thyroid, I think the number one issue I see with my patients is dry eye and dryness, and that is a whole nother topic in itself. But typically my patients with thyroid conditions, there are going to be findings on the eye. And it's something that thyroid eye disease specifically, to qualify for Tepezza or other drugs, it is something that does take a lot of diagnosis and care and follow-up and exams on that. But there usually are some forms of conditions or symptoms in the eye from thyroid eye disease, or from the thyroid hyper or hypo,
Sure.
or the medications from it.
It's all one system, and they're all related, and the eye just pulls it all together. And I think that has been underestimated for a long time.
Well, I know, especially patients who are on Synthroid, they know about the T3, the T4 levels, the THS levels, and things like that. But the antibodies, and that's where it can get bad with the eyes, certainly dryness or certainly just redness, hyperemia, inflammation. But if it gets to where you get antibodies attacking the orbit of the eye, you can get the fat in the muscle enlarge, which could lead to proptosis or bulging forward of the eyes, and could actually even lead to orbital decompressions in some cases. So certainly it's all stuff to be aware of, and for the patient, if you have any of these conditions, eye pain, redness, certainly come in and see us, because even the simplest thing, if it's caught early, we can help you versus, it being there for a good while.
That's the beauty of primary eye care, that you see such a wide variety of things that you're very attuned to picking up small pieces of the puzzle that may not be automatically related to other things. And you have the time to devote to looking at those correlations. And that's the benefit of a primary eye care practitioner, particularly if he has the equipment to analyze all those specific parameters, as opposed to going somewhere that doesn't have that.
Sure. And that helps us. I mean, we want to be as proactive as we can to hopefully prevent a problem before it ever gets to be a problem. I mean, that's the goal, certainly, by doing the things and looking at that. I guess switching, we're kind of going from one to the next, so feel free to go back in if you want to, but glaucoma, certainly we can talk probably, 2 or 3 shows about glaucoma, but in general, what would you say as far as glaucoma?
So what I like to emphasize on glaucoma is it's something that I'm looking for on every patient who sits in my chair. I'm looking at front to back of the eye, pressure of the eye, risk factors in the family, their prescription, and then looking ultimately at their optic nerve, which is the structure that glaucoma affects. It's the main structure that takes everything from your eye to your brain. You can kind of think about it as a wire. And without that wire working well, that's how sight is lost. And the biggest thing I emphasize is that glaucoma is a symptomless disease until the very end stages. And so the number one way to catch glaucoma is a routine eye exam, checking every year and making sure that we're looking at those structures, imaging them, looking at your risk factors, and taking in anything we can to catch it sooner than later and really try to do our best to prevent any sight loss. And in the world of glaucoma, there's a lot of new studies out, there's a lot of new treatments. The standard is definitely changing there in the benefit of the patients. So there's a lot of good, exciting things in glaucoma. The hardest part is just making sure patients come in and us catching it in time, because we can't undo any of that damage once it's done.
I think those insidious eye diseases like glaucoma are the very reason why you should get checked. The 3 of us just attended a seminar in Sandestin, and one of the lectures was on a corneal disease. Cornea is the front of the eye, and this corneal disease was keratoconus. And they've just revised the age-old incidence of that disease from one, I thought he said was in 10,000, but I'm not sure, to 1 in 375. And that's a huge order of magnitude change in the incidence of this disease. And the problem is that the computerized technology wasn't there to detect it prior. And if you get the disease, here we go again, if you pick it up quicker, you can resolve it without drastic surgery and other complications to the eye. It can be treated.
You can prevent sight loss.
It can prevent sight loss and can be treated much more calmly, less drastically.
Less
invasively. Yeah, less invasively.
Well,
I guess that's the right word.
yeah, to that degree, I mean, and that's, it's not like the treatment is anything to lose sleep over. I mean, there are surgery options that are out there, but a lot of these patients that we see, we may start them on an eye drop. They just use it bedtime just to lower the eye pressure. And so would you rather do that at an earlier point or come in with, with a significant visual field loss that you will never get back? And so that's the reason it's so important to get the exam. Certainly, let's look at this. And if you need to be on drops, again, it's not the end of the world. I mean, so a lot of patients, I think, are reluctant or scared. And the treatment, again, is nothing to be worried about, I guess I should say.
The U.S. has never been big on epidemiology or prevention. It's always emphasized the endpoint and the drastic, drama-driven stuff at the end of the curve, when in fact, doing it on the front end in any type of disease is always more cost-effective and easier on the patient.
Well, that glaucoma is certainly, family history, genetics. We always ask that on our intake forms. Do you have any family history of glaucoma? Because certainly it does increase your chances if there is some of that family history. And the other one that we always mention, family history, is age-related macular degeneration. So as far as family history, increased risk, what to look for, what are things that we're checking with that?
Oh, absolutely. Yeah. It's the #1 cause of blindness in people over 55. And its incidence is increasing, which is scary. There were some initial studies that correlated it with the tau proteins in the brain with Alzheimer's, but those have since fizzled out. But certainly the circulation and the vascular factors that are associated with both of them, there's something there, it just hasn't been discovered yet. Everything is the emphasis in that disease is on treatment with injections and surgery and this. But the trick is to find out what the causes were, and instead of just mopping up the water on the floor, to fix the hole in the roof.
And the #1 cause that we know of is nicotine intake, and it's cigarette smoking. So we do know that, as well as not smoking cigarettes, wearing sunglasses, and then having annual exams, especially if you have in your family history, to find those things earlier and to make those lifestyle adjustments and to try and get on treatment. There's new treatment in the macular degeneration world even now.
Yep. And I think that's one of the big, since I graduated school, that's one of the big advancements is related to treatment of age-related macular degeneration. Used to be we could just give them vitamins and supplements and hope for the best, but now with anti-VEGF injections, there's a lot more out there that certainly help patients to slow down and maybe, not only halt, but sometimes improve vision.
There's a new instrument out now called the Maculogic, which there's only 2 in the Panhandle, but we have one, and it can pick up objective signs of the macular degeneration 2 to 3 years before a clinician can see it. So if there's a family history, you want to run this test and pick it up even before it's going to show up, and that's amazing. So I see virtual reality and artificial intelligence playing a more and more major role in detecting these conditions at a much earlier phase.
And on top of that, they now have, if you do have macular degeneration, or if we find it in your annual exam, and we talk about those risk factors, there are in-home monitoring systems now that we can prescribe and have work with you in your home so you can at home monitor your macular degeneration. And that's really exciting because the sooner you find a change in macular degeneration, we can get you treatment, the better. And
that's a big improvement because it used to just be an Amsler grid with kind of boxes that we would kind of self-assess that way. So that's a big improvement with that.
A great improvement.
We covered, I think, the big topics there. Thank you for joining us here, Dr. Jean Teresa and Dr. Hannah Sahani joining us on this one. I want to kind of go through and just, don't forget to like, rate, and review the podcast with whatever you're viewing us on as far as whatever channel or station. We appreciate it. Certainly give us feedback, any questions, and come see us. Come see us if you need an eye exam or if you have an office visit. We take, like I've said before, pretty much every vision and medical insurance that's out there. Certainly give us a call. We may be booked out a few weeks as far as full exams, but certainly if it's an office visit, an emergency, we try to get you in same day or as soon as we can if you have a condition that's really bothering you or painful or red or anything like that.
And I can assure you, if there's any negative feedback, we will accept that also. And I don't want you to worry about any retaliation of any type. We're more civilized than that, at least so far.
Thank you very much. Thank you.